Okay. So, dear colleagues, welcome to this webinar organized by the ESC Council on Valvular Heart Disease. And the title is extremely promising: Tricuspid Valve Regurgitation Management, What is New? You know that it's a really hot topic. It's a new topic that we need a good group to deal with that. And we do have a good group. Professor Bax will be the chairman, and I co-chair with him. I'm Dr. Vahanian from Paris, and we'll have two outstanding speakers, Dr. Marta Sitges from Barcelona and Dr. Fabien Praz from Bern. And they are going, or we are going, to try to cover several issues which are called learning objectives. Firstly, to highlight why tricuspid regurg is important. Is it good? Is it bad? Can we change a little bit the outcomes? Then we'll discuss what are the current results of the tricuspid intervention with a special focus on transcatheter tricuspid intervention. We'll have a look at the selection of the patient for this procedure. And finally, we'll discuss the very important role of echo, first to select the patient, second to guide the procedure. So it's a fantastic agenda, and we are going to seek for your help because it's not an information session, it's an educational session with a lot of interaction. So you'll have MCQs, and more importantly, since the very, very beginning of the webinar, you'll be asked to pose as many questions as you want on the chat, and we'll do our best to answer this question. So we're almost ready to start, but we have to say thank you to the Abbott company, which sponsored the event. So now I pass the mic to Marta Sitges. Please, Marta.
Thank you, Professor Vahanian. And thank you for the European Society for having invited me to participate in this webinar. So these are my potential conflict of interest. And let me start introducing our patient, our first patient, Mrs. XX, let's call her. She's a 79-year-old female. She explains that she has had high blood pressure for more than 30 years, but apparently she was well controlled with enalapril and hydrochlorothiazide. She reports that she has chronic persistent atrial fibrillation since 10 years ago. And now she comes to us because she complains of progressive fatigue and shortness of breath, and she shows up with ankle edema in both legs. She's her family physician has been prescribing furosemide. Now she's in a doses of 80 milligrams per day. And now when we see her, her blood pressure is 90-60 millimeters of mercury. Otherwise, she doesn't report any other medical previous records, but she looks like a old lady, a small old lady. These are the results from her blood work labs. So she has mild renal insufficiency with a creatinine level of 1.6 milligrams per deciliter. She has some elevation in her hepatic enzymes in transaminase. She has elevated NT-pro and BNP. These are the reference levels in our institution. So as you can see, very elevated, indicating elevated filling pressures in the heart. And these are the different scores that we calculated for intervention in this particular lady. So you have the Euro score was almost 4%, STS score 13%, and the TRI score, which is a recently developed score, recently developed for specific patients having tricuspid regurgitation and proposed by Jill Dreyfus, not Gilles, but Julian, sorry, Dreyfus in France. So with this score, it's predicted that his risk of in-hospital mortality for surgery will be around 14%. Let me show you the echocardiography, the transthoracic echocardiography of this lady. As you can see here, there is severely dilatation of both atria. As you can see, also the right ventricle looks enlarged as we compare to the left ventricle. Here you can see that there is mild mitral regurgitation, and when we focus on the right heart cavities, we see that there is important, let's call severe tricuspid regurgitation here that has a wide vena contracta here and a regurgitant jet occupying more than 50% of the area of the right atrium. So these are the more quantitative findings. So the patient had vena contracta width, so the narrowest part of the regurgitant jet, which was 15 millimeters, that corresponds to severe tricuspid regurgitation, dilated right ventricular. These are the dimension at end diastole of the area of the right ventricle indexed by her size, mildly reduced RV function with a TAPSE of 18 and a shortening fraction of 45%, severely dilated RV, RA and LA, as I said before, with a normal left ventricular systolic motion. Ejection fraction was normal, and there was mild MR, and the aortic valve was normal. Patient underwent right cath, and these are the values of the pressures that were found in the right catheterization study. So as you can see, there was no pulmonary hypertension. Pulmonary pressure, the right pressure in the atrium was a little bit elevated here. And here I would like to ask you and start our interaction with this first question. So you can vote in the platform that you have, and there you are able to vote, and the results will be shown in 30 seconds. My question would be, at this point, we have this lady, 79, 5-year-old, mild renal insufficiency with this severe tricuspid regurgitation. So what should we do at this point? We should increase the diuretics. We should send the patient to surgery because she's low risk. We should do nothing. This is an elderly, fragile patient, and so that's high risk. Or we should go for a percutaneous intervention. So please send your answers so we can discuss a little bit what are the options. So remember, we can increase diuretics. She was already on 80 milligrams per day of furosemide. Surgery, nothing, because she's high risk, or we should undergo percutaneous intervention. Please send your votes so we can see the results of the poll. So do we have them? We still people voting. Remember to send. So maybe we don't have the results of the poll.
Yeah. I'm seeing what I'm seeing here is quite clear. So 139 votes, 65% says percutaneous intervention, 24% says increase diuretics, 7% says go for surgery because a low risk patient, and 4% says we go conservative, we do nothing because surgery is high risk in this elderly fragile patient. So 65% votes for percutaneous intervention. I think that gives you some idea about the way the audience is thinking about this.
So I think it's interesting, the first answer, to increase diuretics. That's an option, but I would like to remember that this lady had a blood pressure of 90, 60 millimeters of mercury. So and already was on 80 milligrams of diuretics. So the thing here is how much should we push medical therapy? Of course, that's the first step to optimize, but how much should we push that if the patient is already not hypotensive, but still already in the limit? The other option, surgery, is a potential option, but remember the scores for in hospital risk of mortality was up to 14%. Let's go to the European guidelines that were recently published last summer, almost 1 year now. So if we go to this patient who has functional tricuspid regurgitation, severe secondary tricuspid regurgitation, patient is symptomatic, she has right ventricular dilatation. So here we have the option, as discussed before, of increasing more the diuretics. We have the option of surgery, but we have to keep in mind that this is an old lady and particularly with kidney impairment, function impairment. So we know that patients with renal insufficiency undergoing cardiac surgery is usually a not very good combination. So we have to keep in mind this new option that has been acknowledged by the European guidelines, still with a 2B level of class indication. But this is the approach that most of the people have suggested, and indeed was, as we will see, one of the options that we consider. So what are the criteria for selecting these patients, or what are the criteria to decide if TR transcatheter edge-to-edge repair, which is one of the most used techniques in the percutaneous field in tricuspid regurgitation, a patient is suitable or not for that therapy? We have to consider mainly three factors, or three group factors, which are anatomical factors, clinical factors, and also imaging factors. Why? Because we mainly need echocardiography to guide the procedure, so we need a minimum of quality of acoustic window for the echo to see and to guide the procedure. Of course, TR has to be severe, and ideally right ventricular function should be preserved or mildly impaired. This was the case. No pulmonary hypertension, and ideally no leads inside the heart, ideally. And then we go for the anatomical factors. So what's the functional anatomy of the valve? And this is why imaging again comes important here to evaluate which is the anatomy of this valve. We have the Tricuspid system and other systems in the market. What they do is they mimic the Alfieri stitch, as you know, and mainly what we need, as I said before, is an adequate visualization of the tricuspid valve, and it's very important that we go through a systematic evaluation of all the valve, of all the geometry of the valve, all the functional anatomy of the valve, to understand what's really happening into the valve, and that we are really sure that we have enough tissue to grasp with the device, and that it's important also to speak the same language with the team that is approaching the patient and treating the patient. For that, from the echo point of view, what we do is we go through a systematic evaluation of the tricuspid valve, not to forget anything. So we have like a mental scheme of what we have to see and what we have to look for. But there are especially two particular views that I want to focus and that I want to review, which is the transgastric view. That's our first mass, where we see, this is the only view where we see all the leaflets. And importantly, we have learned now that the tricuspid valve is not always tricuspid, and many times even being tricuspid has many indentations that may pose a problem or may mark our strategy on how we are going to do this TR or this edge-to-edge repair percutaneously. It's also important to compare always black and white images with color Doppler to look where is the origin of the jet and to trace our roadmap of the strategy of repair. So here we see typically with the aorta valve, the aortic valve, we put as a reference landmark at what would be 5 o'clock in a clock representation. So we have the posterior aspect, the septal leaflet, and the anterior leaflet here. Also very important, the biplane. So for this, I would say 3D echocardiography is important to have, and particularly the biplane, where we do a scan from the more anterior part of the tricuspid valve to the posterior aspect. So we start with this RV inflow-outflow view. It's coming from a short axis view in the transesophageal view, where we have the aortic valve in the middle, and with the biplane scan, we cut it from anterior to posterior. So we see the perpendicular plane here, so we can see in the anterior part of the tricuspid valve here with this yellow line, in the mid part and in the more posterior part. So we can scan all the valve and see what's the coaptation or the surface of coaptation loss here, and we can see how big is this gap that of course we can also see in the transgastric view. Also important to compare with color for the same reason. So here we are cutting the valve in the middle, the tricuspid valve in the mid part, and we can see that this is the largest origin of this jet. With this, we can understand what's happening on that valve. So from there, we can infer what are the mechanisms leading to this tricuspid regurgitation, and we can plan the strategy to treat it. So again, going to quantification, as said before, this was the transesophageal of this lady. So here we can see that there was a large jet, vena contracta was 15. We measure a gap of 7 millimeters here also. And these were the other views, the biplane of our patient. So it was mainly a central jet. We can see here in this biplane view, which is calling in the close to the anterior septal surface of coaptation of the valve. So in the mid part, as you can see here, and here you can see the gap. There's long leaflets here, a little bit restriction of the septal leaflet, but still something that you can go with the clip and bring the two leaflets together. So going to the transgastric view, the image here was not that good, but it's good enough to see that this is a central gap and this is the central origin of the jet. So mainly this is what we are also looking for here. There was a small indentation here in the anterior leaflet, but otherwise there were more. And here is the 3D aspect that confirms the origin, the central origin of the jet. So at this point, I would like to launch the second question. So what do you think in this patient? Remember, we were approaching this lady, this old lady, elderly lady who was symptomatic, renal insufficiency, and we are planning TR on this patient. Do you think, according to the echo that you have seen, the anatomy is feasible to perform it or not? Or maybe you need more information. If you want, say no. If you need more information, I should have had the third option, but we don't have time at this point. So if you think yes, the lady is amenable to receive transcatheter edge-to-edge repair, say yes, according to the anatomy and to the clinical presentation. If you think no, or that you need more information, say no, and please respond, so we can discuss a little bit on what we did and what were the outcomes. So I'm not sure that we already have the results. Your backs.
Yeah, I'm looking at the results right now, and it went a little bit back and forth, but in general, 178 people voted, and 89% of them voted yes for TR feasible, okay, which leaves 11% that voted no. So that gives you some solid ground to continue your case, because actually I also think that this was a very good case in terms that TR is feasible. So please go ahead and show us what happened.
So what we did was we decided to go because the gap was 7.5 millimeters. I mean, it was not so, it was doable. Particularly the length of the leaflets was also good, the mobility. So we decided to go. It was a central jet. These are anatomic factors that favor this therapy. So we implanted the first clip here. As you can see, we are in the transgastric view. The aortic valve is here. So that what we did was put a first clip here, and that was the initial result after the first clip. So we decided, of course, to go for a second one. That was the initial plan. This is why we started more anteriorly, to avoid the acoustic shadowing. If we started more posteriorly, and then we went, of course, more posteriorly, and this was the result, the immediate result after the second clip here. So as you can see, we underwent from severe to mild residual TR here. And now, after this successful result, I would like to ask my last question. So after this result, what would you do next? So the patient is extubated in the cath lab, she goes to the ward, and she can be sent home the next day. She's doing fine. So what do you recommend at this point? What would you advise her to do? Would you reduce immediately diuretics because the TR has gone down? Would you reduce diuretics but later on? Would you expect right ventricular reverse remodeling, or the last option is 2 and 3? So please vote what you think. So would you reduce immediately? Would you wait to reduce diuretics? Would you expect or not right ventricular reverse remodeling in this lady? So
yeah, I see some fluctuation, but I think what I'm seeing here is 172 voting, and the big winner is your answer number 4, for 2 and 3. So this is 2 and 3, 80% actually. And so reduce immediately diuretics is 6%, postpone the reduction for 3 months 5%, check for RV reverse remodeling is 9%. So please discuss for a few seconds with us.
So this is something that also we have learned in recent years. So our first reaction was to immediately reduce diuretics, but later on we started postponing this reduction to allow this reverse remodeling to occur. And then we saw that patients were doing much better. So now typically what we do is we hold on, we maintain the same dosage of diuretics, and we hold the decision to reduce it for at least 3 months. This is what we did in this lady. This is the baseline echocardiography, and this is 18-month follow-up, so 1.5 years after. As you can see here, there was reduction, not elimination, but significant reduction in the amount of TR. And note that the reduction of the right ventricular size and even the atria was reduced. These are the clips that are correctly attached here, but it's quite significant, the reduction or the reverse remodeling, the reduction in the cavity, in the size of the cavity of the right heart, and particularly the vena cava diameter, that these patients that have a successful repair of tricuspid regurgitation, even if not eliminating all of it, just by reducing tricuspid regurgitation, we see these effects in the follow-up of these patients. So I think this was, this is another slide showing the same, the reverse remodeling. So to sum up, I would like to highlight that it's important to have this systematic evaluation with echocardiography, also, of course, clinically of all the symptoms of the patient, of course, optimizing the therapy. But then when we have to decide if a patient is a good candidate or not, and the idea of showing this first case, it was like a good candidate, not perfect, but almost perfect patient with a systematic evaluation to really understand what's happening on the valve. It's important for guiding the therapy because the echocardiography is the eyes of the interventionalist during the procedure. It's important to have a dedicated team on tricuspid valve disease, and that we have now new options to treat tricuspid regurgitation in what were or that still are very sick patients. And therefore, adequate selection is important, not only from an anatomic point of view, and we can discuss on that, but also to avoid futility in these patients. And maybe, we don't know, we still have the question, the time has come to treat more definitely and probably earlier these patients that now were largely neglected for therapy because up to now surgery was the only potential therapy for them. So thank you very much for your attention.
That was a fantastic talk, Marta. Really very, very nicely put together. I really enjoyed it, and I'm sure the audience enjoyed it because what I'm seeing is coming a lot of questions to you. So let's just try to take it step by step. One of the questions that starts with is, the established criteria for TEER. Could you summarize that maybe one more time for the audience? Because that is, I think, very important fundament of what we just discussed here. What are the established criteria for patients to be eligible for TEER?
Yeah, I think that it's difficult to say established criteria because this is a very dynamic process and we are continuously developing and learning. So I would say that the established are severe tricuspid regurgitation in patients who are symptomatic and currently are assessed by the heart team and are considered to be high risk for surgery. Apart from that, then we go to the three groups of variable I was talking. Of course, imaging plays a key role, not only for the diagnosis, but for guiding procedure. So in the very rare case that there is no echo window, I mean, we cannot do the procedure, of course, but that's very, very rare. And now we have more and more tools because we have transesophageal, we have intracardiac, and even transthoracic. So by combining the three, most of the times this is sorted out. The second group is the clinical aspects of the patient. So, and there we have the presence of pulmonary hypertension, the presence of right ventricular dysfunction. We know that the worse the right ventricular function is, the worse the probability of improvement will be in these patients. But still we don't have real cutoffs. We have orientation, but we don't have real cutoffs. So ideally, patients with preserved or mildly reduced right ventricular function. Same for pulmonary hypertension. So ideally, no pulmonary hypertension. But we have also evidence, and we are learning on that, that even patients with moderate or even severe pulmonary hypertension, if that's precapillary, they may improve. So still no perfect cutoff points, and that's, we know medicine is a continuous variables always. Still no clear cutoffs, but the idea and the concept is that the less pulmonary hypertension, the most probability to improve. And finally, there is the third group of variables who are the anatomical factors, okay? And for that, again, echo and imaging are important in order to really see what's happening to the valves and if that dysfunction made by the lesions that the valve has, as the surgeons used to do, is treatable or not with this type of devices in the case of catheter H2H repair or other devices that may exist. Okay, that's the three groups, the three important groups of variables that determine the possibility of doing this therapy in these patients.
Really nice, but also complex to start with and to build your program. But as you highlight, the imaging is very important. One of the questions that also comes here is very clinically oriented also. So what about the long-term results of this procedure? Are they really prolonging life, or do you think that this is a more symptomatic treatment?
Well, we don't have the answer right now to that. We only have indirect data. So we have data from the early experience with a non-dedicated device, the mitral clip, put in the tricuspid position, and that comes from the Trivalve registry in Europe. There, I mean, the outcomes have been showing an improvement in functional class, also this reverse remodeling, and also in quality of life. There is a retrospective study comparing two cohorts of medical therapy and transcatheter with mitral clip, I'm saying, and there was a benefit also in survival. Then there is an ongoing trial, which is the Triluminate trial, which is the randomized trial with a dedicated device, which is the TriClip device, and it's comparing the medical therapy arm with the interventional therapy with the TriClip. So we have to wait for these results, but we have to keep in mind that the good story or the good news of this therapy is that it's a very safe procedure. So of course futility is something that we don't want, but when the safety of the procedure is very high, this is something that also has to be put in the balance, because of course we want patients to live more, but also quality of life and well-being is also important.
Wonderful. I think you summarized it beautifully, and that is indeed the most important thing. Living long is important, but probably quality of life is even more important. I'd like now to ask Alec to introduce the next speaker, because we're already getting short on time, but there are so many questions coming in and the discussion is good. But Alec, please, let's move to the next part.
Thank you. Congratulations, Marta. Thank you, Yaron. Now we'll move to Fabien, who's going to tell us about an even more complex patient with multivalvular disease. So, Fabien, the floor is yours.
Thank you very much. Thank you, Alec, Jaron, and Marta. I mean, after this very nice case of isolated secondary tricuspid regurgitation, I would like to show a little bit of different context with a patient with secondary tricuspid regurgitation in the context of multivalvular disease. So here are my potential conflict of interest. And here you can see our patient. So it's an 85-year-old female, quite a frail woman. You can see here a little bit of diminished BMI. She's quite small and had a recurrent heart decompensation with clear symptomatic of right heart decompensation. But she also has shortness of breath with an NIYHA class 3. She had, like most of these patients, chronic atrial fibrillation and received a pacemaker due to sick-sinus syndrome. She's not completely pacemaker dependent, but had in association to atrial fibrillation some disorder and received a pacemaker years ago. What you can see here, so it's a little bit a more complex situation. We have a patient that has been pre-operated years ago for myxome excision, and she had the closure of an ASD as well. That was a long time ago, and now she presents with moderate. You will see that it's more like moderate to severe primary mitral regurgitation. She has, in addition, severe secondary tricuspid regurgitation. She had some kind of pulmonary hypertension as well. We will come back on that in more detailed way. And as I already mentioned, permanent atrial fibrillation. And like I would say 70% of this patient, she also had chronic kidney disease, which limits in that particular patient the medical treatment. So you can see the situation here on transthoracic echocardiography, quite an impressive one. So you see the dilatation of the right part of the heart. The left side, in terms of function, is quite preserved with the left ventricular ejection fraction of 55%. You see here the quantitative measurement of mitral regurgitation with the regurgitant orifice area of 0.28 and the vena contracta of 5. So we are between moderate and severe, I would say, for secondary MR, moderate to severe, actually what we would call a grade 3. Then we have the right ventricular function that is also moderately reduced, TAPSE is 13, and we have a DTI of 7.7 with a huge dilatation and a coaptation gap that is about 13. The regurgitant orifice area was calculated to be around 0.6. So as you can see, very severe tricuspid regurgitation, which was actually also, according to the clinical presentation, the leading lesion in that particular patient. The right ventricular pacemaker lead was actually not supposed or were not expected to be the reason for tricuspid regurgitation. So there was no leaflet interaction, and the gradient that was measured in this TR jet was about 19 millimeter of mercury. So what we have to deal with here, and that's actually the new classification we propose in our review in neurointervention, what you can see here that we make the difference between atrial and ventricular secondary tricuspid regurgitation. And in that particular situation, we are in the situation of a ventricular tricuspid regurgitation, probably due to the pre-operation of the patient. The patient, you remember, had passed open heart surgery, and that's maybe also the reason why over time she developed predominantly ventricular tricuspid regurgitation together with atrial fibrillation that may also play a role. Then we make the difference also with patient having a pacemaker-induced tricuspid regurgitation. That's not the case in this particular patient. but we need to look at, in all patients having a pacemaker lead, look at interaction of this lead with the valve leaflet. And finally, we have the most rare form of tricuspid regurgitation, which is the organic one, about in 5 to 10% of the patient. So we did a right heart catheterization, as we perform always in this patient with severe tricuspid regurgitation. And you can see that it's quite impressive, actually. We have, and that's not completely unexpected, looking at the coaptation gap, we have a ventricularization of the right atrial pressure. You see that the V wave of the systolic V wave of the right atrial pressure is 39, compared to a systolic pressure in the right ventricle that is 44. Then we have an elevated pulmonary pressure. The mean is 33 millimeter of mercury. We have an elevated mean wedge as well, a relevant V wave, 26 millimeter of mercury. And what we like to look at also in that situation, because we underestimate the pulmonary pressure in presence of severe tricuspid regurgitation, is the resistance. And you can see that the resistance is only slightly elevated. The normal value would be about 250, and we have a 320, so slightly elevated resistance. So we went for the supposition that we assume that we had a predominantly secondary pulmonary hypertension in that patient. No relevant coronary artery disease, and you can see that we had some late sign also of severe tricuspid regurgitation, with, of course, I mentioned this already, renal dysfunction, but also some slightly elevated liver function going into what we call a cardiohepatic syndrome. NT-proBNP was, of course, also elevated. So you have heard about this. All the score we had until now performed not well in patients with tricuspid regurgitation. That's why there is this new Tri-score. And if we look at our particular patient, so we see that in the scoring, she is more than 70. That gives her 1 point. She has an NYHA class 3, 1 point. She has right-sided heart failure. That gives 2 points to our patient. She has left ventricular function that is actually less than 60. And finally, we ended up with having a patient with a Tri-score of 6, which give a predicted in-hospital, that's important, it's predicted in-hospital mortality of 22%, which is quite high. If we go to the medication of a patient, so I mentioned that renal function was a bit the limitation, but she still had a quite good medication with 20 milligram of thorazimide, spironolactone in addition. She was on 100 milligram of metoprolol, had an ACE inhibitor in a low dose, and finally was anticoagulated because of atrial fibrillation. So that's a summary of the patient. Previous open heart surgery. We have moderate to severe mitral regurgitation. We have severe secondary tricuspid regurgitation, mixed pulmonary hypertension, but predominantly secondary. We have recurrent heart failure hospitalization for right heart decompensation, and we have the pacemaker lead without leaflet interaction. Here's the images again. That's mitral regurgitation. You can see that probably we are at the border between moderate and severe. And that's a tricuspid regurgitation. You can see this very large coaptation gap, and also the moving right ventricular lead without any interaction with the leaflet. And then we had the CT scan, which can be very useful also in patients with tricuspid regurgitation to assess the anatomy more details. You can see this very nice high resolution with the contrast medium on the right side. You can see the movement and the position of the right ventricular lead. So that gives us some additional information, in particular if we envisage to have a therapy of the annulus. And then finally, to confirm severity of the valvular disease, we went to an MRI. So we did an MRI as well, and you can see that broadly we confirm what has been shown on echo with preserved left ventricular function. We had a regurgitant fraction of 46% for mitral regurgitation, which is relevant. And then, of course, very severe tricuspid regurgitation. You can see the regurgitant volume of more than 120 and a regurgitant fraction of 74, with a diminished cardiac output. That's a non-index value, 3.1, but this gives quite a low cardiac output in this patient with body surface area of 4.6. So maybe we can come to the question. So there will be a poll launched now. What would you do in this situation? You have 30 seconds to answer and choose the best option for you. The number one, to increase the diuretic dose. That's the first option in this patient. Do a redo open heart surgery. Patient is preoperated, but you may think that because of the combined valvular heart disease, mitral and tricuspid, we should reoperate on that patient. Evaluate a transcatheter intervention. That's number 3. And finally, conservative treatment because of the presence of a pacemaker lead, and increase pulmonary vascular resistance. So once again, first option, increase diuretic dose. Second, redo open heart surgery. Third, evaluate transcatheter intervention. And 4, conservative treatment.
So here on the colleagues voted, 117 voted, and there is a real plus for evaluate the transcatheter intervention. So 68%. Please go.
So
evaluate.
That's what we do actually. So we were thinking, looking at the TriScore high in-hospital mortality, that it's probably too high risk to redo an open heart surgery, and increasing diuretic dose was limited by renal function, which was also aggravated in the context of increasing the diuretic dose. So we went for this evaluation. So that's a kind of I would say, usual situation in that collective, in that cohort of patients. So you can see, and this patient has the both characteristic on the right, that's a patient after left-sided surgery, or after surgery, I would say, where you can see that about, I would say, 10 to 25% of the patient, even more in some studies, develop right heart failure and severe tricuspid regurgitation. So that's actually matched to our patient. And the second situation is severe tricuspid regurgitation in the context of relevant mitral regurgitation. You can see that again, about 1/3 to even more than 50% of the patients with relevant mitral regurgitation have also severe tricuspid regurgitation. So I think an important message to follow the patient first having open heart surgery, and second patient having left-sided valve disease for the presence also of tricuspid regurgitation. And the second factor is the presence of a right ventricular lead. So one of the options in the poll was to not to perform a procedure because of this lead. That's probably not what we should do. So a lead is not a contraindication for a transcatheter procedure, but we should look at it in details. That means we should know where is this lead, what is the interaction, is there any interaction of the lead with a leaflet, is there an impingement, is there a perforation even, that can be seen as well, or is there an interaction of the lead with a subvalvular apparatus that can aggravate tricuspid regurgitation. And in some instances, also removal of the lead can be considered. What we know about patients with right ventricular lead is that they can be treated with transcatheter procedure and have about the same success if they are appropriately worked up. If we look at it in details and they don't have an irreversible interaction, they can be treated using mainly the TriClip, the transcatheter edge-to-edge repair, with the same result and the same performance as patients without right ventricular lead. So that's the situation of our patients. So we have a secondary functional tricuspid regurgitation with a lead, but which is not related to the lead. So no need to extract or to look more carefully at this lead. And then the second parameter, as mentioned by Marta before, is the gap. The coaptation gap plays an important role in the selection of the patient and the feasibility of the procedure. And you can see that in our patient, the coaptation gap was bigger. That's what actually was expected here, but we decided because of the comorbidity of the patient and the anatomy to try a procedure. One of the important selection criteria as well, this has been mentioned, is the right ventricular function. Our patient had the moderately or slightly diminished right ventricular function, and that's maybe the sweet spot for the treatment of patients with severe tricuspid regurgitation. You can see in that propensity score match study that the most benefit was seen in patients with slightly diminished right ventricular function. And also the interplay between right ventricular function and the pulmonary artery pressure is extremely important. And one of the positive sign you can observe during the procedure is actually an increase of the pulmonary pressure, meaning that the right ventricular function, or that the right ventricular is pumping more, and that you achieve an increase in terms of cardiac output. So the interplay of both factor and the right ventricular function alone seem to be important in that patient. What do we know? We have mentioned this before. So transcatheter edge-to-edge repair is able to reduce tricuspid regurgitation effectively in a very safe way, but also at 1 year, and you can see in this data, hospitalization in this patient. So in our patient with now a combined valvular disease, what would you do? And there is a poll again where you can answer about the strategy of the treatment. So would you go for simultaneous mitral and tricuspid treatment in the same procedure, mitral treatment alone and close follow-up, or isolated tricuspid valve treatment in that patient? So is that simultaneous treatment, both in the same procedure? Is that mitral treatment alone and follow-up of the tricuspid regurgitation, or are you going for isolated tricuspid valve treatment? So maybe Alec and Jeroen, we can look at the result if you have them.
Yeah, I got maybe 2 more seconds.
We need 2 extra seconds. Okay. So it's a real, discussion debate, but the colleagues did favor simultaneous in 50% of cases, 33% for isolated, and the last one, the loser, is mitral treatment alone.
That's very interesting. So I'm surprised by the result, but that's also what we decided to do. Because our feeling was what tricuspid regurgitation was already very advanced and unlikely to improve. So as you can see, we did a mitral clip on the left side, and in the same procedure, we then go for the implantation of a TriClip on the right side. So you can see after 1 clip, and then we continue actually the procedure with the implantation of a second clip anteroseptal. From posterior from the first one, sorry, the first one was in the anteroseptal commissure. Then we went for the implantation of a second clip. You can see here the grasping with the second clip and with our still relevant tricuspid regurgitation. And then we went for the implantation of a third clip. So it was a three clip procedure, which you can see here in the posteroseptal commissure, with finally a very nice reduction of tricuspid regurgitation. In a patient, there was still a little bit of a jet, so it was not completely away. But remember, the coaptation gap at the beginning of the procedure was 13 millimeters, so quite big coaptation gap. And at the end, we had a gradient of 3, which is probably the limit, but actually still acceptable. And I have a long-term follow-up of this patient. So if you look at 3 months, the patient came back with mild mitral tricuspid regurgitation. We have very good improvement, weight loss, improvement of the renal function, and the BNP was going down. And then at 2 years, again, you can see a durable result. Mitral regurgitation was still mild, I would say, tricuspid regurgitation as well. And it was stable in terms of NT-proBNP and renal function. And we did an MRI also. You remember we had an MRI before, and we could see quite a huge improvement in terms of cardiac output in that patient following treatment of both valves. So I just want to conclude by saying that we have some signal in some comparative studies showing that the combined treatment of mitral and tricuspid regurgitation in patients with multivalvular disease can be of benefit compared to isolated mitral treatment in patients also having severe tricuspid regurgitation from a symptomatic point of view, but also from a prognostic point of view. These are non-randomized data, of course, but give you some glimpse into the future. Thank you very much for your attention.
So thank you very much, Fabien. It was a great talk, very illustrative and complementary to Marta. So we have so many questions. We'll have to pick a few. So Fabien, first, there are many questions about what is your favorite parameters to assess RV function in these patients.
That's a very good question. So what we, I think, and Jeroen will probably agree, we are not good enough in assessing the right ventricular function on our patients so far. So what we do typically on a routine way, we look at TAPSE and DTI, but that's only the longitudinal function. And we have started also in some patients to look at strain, and I think, Jeroen has also a lot of experience, and Marta as well, on this. And strain is actually revealing in some situation, if you compare it before and after the procedure, that right ventricular function may change in that patient. And finally, I think that MRI has also a role to play, and that's why in that patient and in some of our patients, we also encourage our imaging specialists to do MRI to look at it more carefully.
Okay, now we have also several questions about the other devices, not the other leaflet device, but can you just say a word? What is your prospective as regards the use of leaflet device and the others?
So leaflet devices are still the most used now in the treatment of patients with tricuspid regurgitation, because they are easily available, and they are also quite easy in terms of technical challenge. But in some of the patients with a very broad coaptation gap, in patients with more difficult anatomical situation than the patient we show Marta and myself, I think there are other options, and one of the approved options is a direct annuloplasty device that can be used also. And what is coming is, of course, transcatheter replacement, tricuspid valve replacement mainly from the transfemoral access, and that will play also a role in more anatomically challenging patients.
Okay. Another question, and very nicely illustrated in your case, is when should we evaluate the quality of the results? Immediately after 1 week, after a couple of months?
But that's very interesting, and that's come back to what has been mentioned by Marta. We need to wait a little bit. So of course, probably the worst time point is directly during the procedure, because you are still on general anesthesia, and the hemodynamic is different from actually what is a real hemodynamic of the patient. So what we need to wait is at least a day after on TTE with the patient awake, and then we have actually what is the final result. But that's not completely true, because if you continue diuretic, if you wait for right ventricular remodeling, you will see that some of the patients even improve, because with the annuloplasty effect and with the reduction of the volume overload, you will see, and much more than on the left side, I would say, you will see improvement of the right ventricular dimension and further improvement of tricuspid regurgitation as well. So wait a little bit and don't stop the diuretic immediately.
That's a very important point already made by Marta. Now we have to reassure our colleagues. Did you find in any of your patients a tricuspid stenosis after clipping?
That's a good question. So as I mentioned, the mean gradient of 3 is a little bit what we consider to be the limit for having some kind of stenosis, but actually we don't know exactly. So there have been no association between increased gradient and prognosis so far. And I think it's quite difficult to say, and there is a need for further evaluation to say when we have significant tricuspid stenosis that is really clinically relevant. I have never seen it actually in a patient after transcatheter procedure. But we stick actually to the limit of 3 millimeters of mercury and try not to exceed this limit during the procedure at least.
Okay, probably the last question is about the use of NOAC after this procedure in these patients.
So, I think when you implant a clip, you don't need, in particular on the right side, you don't need to have particular anticoagulation. In patients that are naive to oral anticoagulation, and that's a very, very minority of patients with severe tricuspid regurgitation. I would say that about 80 to 90% of these patients have atrial fibrillation and other indication for anticoagulation. You would give in that patient without atrial fibrillation only aspirin. In all other patients, you can use either Coumadin or a NOAC. I think there is no limitation. So the indication, the leading indication is actually most of the time another one, which is atrial fibrillation in the vast majority of patients.
Okay, and maybe one very, very last, because a colleague kindly asked you, well, Professor Pras, why did you use both CT and MRI in such a case?
So the CT was actually because we were feeling that the coaptation gap was too big for treating with edge-to-edge repair, and wanted to explore other options, in particular direct annuloplasty. At that time, there was no replacement at the time we treated the patient, but the feeling was to have all options often and evaluated. We wanted to have a CT scan, but that's the case in most of these patients. In most of these patients, you want to have several options, and that's why you do a CT scan as well. But it's not mandatory if you directly go to edge repair.
Okay, so I think it's already time, and I'd like to pass the mic to Jeroen. We'll make some conclusions. So Jeroen.
So thanks very much, Alec, and thanks very much to the presenters, Dr. Sitjes, Dr. Pras. Really, really wonderful presentations in such a pleasant, didactic, case-based format, and that's what we need. Dear colleagues, I think we learned, all of us, a lot about TR in this beautiful webinar. We learned how to analyze TR, how to classify TR, how to quantify TR. It's not that easy, but the more we get confronted with it, the more we have to master this way of looking at these valves. And we learned that we can treat those patients. We really can treat tricuspid regurgitation with the clip. Feasible in many, many patients. Dr. Sitjes showed actually the selection. What do we need? What do we need is anatomical features, clinical features, imaging features, and we need to bring that together in a clinical, comprehensive way. Dr. Pras then actually emphasized that often is not just TR, right? The disease starts at the left side of the heart and severe MR starts to occur, and then the disease spreads to the right side of the heart, and then TR develops. But we can treat both of these diseases with clips in even one session. Dr. Pras also emphasized something that's really important. We need somehow some preserved RV function. If the RV function is completely gone, then it becomes very, very difficult. I'd like to thank again Dr. Sitjes, Dr. Pras for their excellent presentations, and I want to thank my good friend and co-chair, Dr. Alec Vanyan, and I want to thank Abbott for supporting this session. And then I want to thank you all for joining the session, and hopefully we see us live in Barcelona. See you there.